spend about 15 or 20 minutes talking about I think what you might best describe as the biology of FTD and how it is that that can lead to ALS and to Parkinsonism and to aphasia, not just the behavioral syndrome. I've got a lot of slides, and I like to talk a lot. I've been described as a generous presenter, which is not really a compliment. I will try to get through most of them. I'm probably going to stop halfway through because the second half of the slides are really some will be answers to your questions, and much of the answers will come from the next two speakers. So I'm going to focus on the biology of FTD, and I'm going to start with a case. Now, before I do that, how many of you here are actual caregivers of someone with frontotemporal dementia? How many here has a diagnosis of frontotemporal dementia? No? And how many have ALS? Anybody here with ALS? Or caregiver with someone with ALS?
And I'm questioning.
Okay. And I like to move around a lot. I'll start with this case. It's a 77-year-old woman, a little bit older, and she presents herself. She comes to the clinic, and many of you might realize that doesn't make sense. People with FTD don't come to clinic. They're brought to clinic. So this is a little different than usual. She says, and it was really hard for me to get a story from her, a coherent story, but she says, you know, possibly for the last 6 months or so, I've been having trouble just getting things done. And she described these unusual things. She said, I had a boyfriend who lived on the East Coast, and we separated because he moved from one house to another on the East Coast, and now we're not talking to each other anymore. So that story wasn't that coherent, and I was trying to understand and spending a lot of time with her trying to see, well, is she just depressed? Did she have a breakup and she doesn't want to talk about it in detail? The relationship itself, as I said, was mostly telephone-based. And the move itself led to him not wanting to speak with her anymore. That's a little bit of a red flag. She had recently herself moved into a smaller condo, and she says, I'm so profoundly tired, I can't get anything done. I can't get my stuff together. It's a mess. And since the move, I can't get anything done. I can't remember anything. I'm losing all my papers. I'm missing appointments, and I forget to pay my bills. So this sounds like the kind of thing you would see with Alzheimer's. But there were some more worrisome changes. She says, I don't answer my phone anymore because all I get are calls from scammers. And she admits that she had lost about $1,000 or a few $1,000s over the last few years buying things and not getting what she was buying. When I asked her what she liked to do, she says, I like to collect tokens on the Publishers Clearinghouse. So these are flags that tell us there's something wrong with her judgment. She also admitted that she'd become much more religious and was had experienced at least one occasion seeing St. Joseph. And I spent a lot of time trying to understand a lot of her other complaints, but she had many what we would call somatic complaints about things on her body not going well, and it was really difficult to sort of clarify what she meant by these things. They were a little bit obscure. Her social history is fairly unremarkable. She was born in Brooklyn. She finished high school. She went straight to work after that. She returned to college after and finished a bachelor's degree in her 30s. She was a travel agent and then decided she was going to flip houses. And she did that for a couple of years, but that wasn't working out anymore. And she was a little older, but she hadn't really retired yet. She'd been married once, divorced after 6 years. She had no children. Past medical and surgical history, not particularly relevant. What is relevant here is possibly that her mother passed away at 69 from breast cancer, so we don't have that much more extended history on her. Her father passed away at a very old age, so very unlikely that he contributed any genetic issues. Her sister is a breast cancer survivor at 81 and cognitively intact. And her mother's father, so again on the mother's side, he passed away from some form of mental illness at an age that was undetermined. So those are red flags for possibly something familial happening here. When I examined her, she actually brought a very large bag full of papers and records and things. Again, these are little red flags that we pick up. very difficult to sort of try to get her to focus on the things that we need to focus on, and we only have an hour together, and we spent about 45 minutes of it going through the paperwork. And she focused on things that were not related to why she wanted to see me. Somebody had said she had anemia. It was very mild, but we spent another 10 minutes talking about anemia. Her cognitive testing. How many people here have had or have seen a MOCA being given? Oh. I'm from Montreal. I'm very proud of it. Did participate in its creation. She scored 24 over 30, which is actually pretty good. 26 is the cutoff. Her memory was intact. She scored 4 out of 5 on the memory testing. And she had difficulties with executive functions, concentration, and abstraction. Her neurological examination was fairly unremarkable. She had, and I don't usually write this down when I see patients, but she actually had increased reflexes. They were very brisk. And one of the things that she complained about the most was that her voice had changed in an unusual way. And I, again, spent a lot of time trying to understand what she meant by that. But her voice was a little bit nasal, like this. Just a tiny bit. And many people speak that way. When I get a cold, I speak that way. So I didn't think much of that at the time. So this is her MOCA. And as you can see, she has a lot of trouble doing the trails B. That's going 1A, 2B, 3C. She's really having a lot of trouble with that. A little bit obsessive on the cube. She started coloring it. I stopped her from doing that. No difficulties with naming. She registers pretty well down here. Registering okay. And then some other points that are interesting. I said her memory was intact, so she's actually remembering 4 out of the 5 items. But she had trouble with repeating sentences and a little bit of trouble with abstraction. This was her clock. She quickly put in the hands before I got a chance to tell her how I wanted the hands to be put in. And then she had some trouble. She put in similar sized hands, and then I said, well, which one's long, which one's short? And she confused the two. So the time that we ask people to place on the clock is 10 after 11, and this is actually 5 to 2. No difficulties with copying per se. This was her sentence. I asked her to write a sentence. My family is Jesus Christ, Virgin Mary, and St. Joseph. So I called this behavioral and personality change. I think that this was a definite departure from who she used to be. Anybody here want to venture a diagnosis? We're at an FTD conference, so is this FTD? It's not a strong case for FTD, though, in part because I don't have a partner. I don't have anybody to tell me more information. But I did my usual thing. I sent her to neuropsychology. I did an MRI. And because of the speech complaints, I sent her to, for a speech evaluation. The MRI came back as diffuse atrophy, no significant vascular disease, and I'll show you what I mean here by preferential involvement of the bilateral temporal poles, but there was focal atrophy in addition to the diffuse atrophy. The speech evaluation came back about a month after I sent her, and I was struck, and I felt bad. The speech pathologist said there's dysarthria, there's dysphonia, there's dysphagia. This is motor neuron disease. So I missed it. I missed it completely. This is her MRI. And just to put things in perspective, the way we think about this, this is the base of the brain. This is the very top of the brain. And you can see the eyes here in the front. Just behind the eyes are where the temporal lobes are. And I think you can probably all appreciate that her temporal lobes are very abnormal. Sorry. So you can see on your right that the temporal lobe should really fill those areas, and they're not. So this is focal atrophy of the temporal lobes. So I brought her back, evaluated her. I thought that questioned her some more, and she said, "Oh, I'm much more spiritual now. I know that God is looking over me, and I know I'll be fine." There were increasing problems with her her speech and her swallowing. So whatever she had had initially when I saw her was progressing fairly quickly. I took a closer look at her neuromuscular exam, and at the time it was obvious that her tongue had shrunken, and although I didn't see any fasciculations, that's sort of spontaneous contractions of the muscles, it was weak. Her proximal muscles were weak, and she also had frank fasciculations of the muscles of most of her limbs. Do you know what fasciculations are? No. We've all experienced them. This is an example of fasciculations. You can see these little contractions of the muscles that are spontaneous. We sometimes experience these when we've had too much coffee or we didn't sleep enough, our eye kind of twitches. Well, this is twitching of the muscles all over. And it's not pathognomonic. It doesn't mean, oh, it's absolutely ALS, but it's a telltale, a very bad telltale for ALS. So my diagnosis then is dual. It's a dual diagnosis. I think she has FTD based on some of the changes. She's still always coming alone to her appointments, unfortunately. And that's based on these sort of soft signs of a personality change, hyperreligiosity, the perseveration that I was seeing in clinic, and the MRI findings. And the ALS is a little bit more solid diagnosis. She has a progressive weakness, she has increased reflexes, that's another sign of ALS, and she has fasciculations. And they did a full study, they did EMG studies and confirmed the diagnosis.
What sort of reflexes are you talking about? Body reflexes?
With the hammer.
Oh.
Yeah. Yep, elbows, knees, very wrist, like that. Yeah. So I'd like to go over three things now. The first is, where does FTD start? What is it that starts when FTD starts? And what are the mechanisms that lead to that pathology? This is the brain, and as you can see here, there are a number of abnormal proteins. So in all neurodegenerative diseases, in almost all, there's always something that we can see in the tissues when we look at them under the microscope. In Parkinson's disease, there are Lewy bodies. In Alzheimer's disease, there are plaques and tangles. In FTD, there are also inclusions or abnormal proteins, but they're not the same in every person. And that's what makes FTD pathology a little bit difficult. But this slide is meant to sort of remind us that every single disorder, neurodegenerative disorder that we deal with, Prions diseases, mad cow disease, frontotemporal dementia, Lewy body dementia, Huntington's disease, they all begin via the accumulation of abnormal proteins in a particular part of the brain. Now that's important because which part of the brain gets involved first will tell us which part will manifest as very specific symptoms. So if the part of the brain that's involved first is the right side of the frontal lobes, then social skills will fail, because the right side of the brain is very important for social skills. If the left side of the brain is involved, you'll get language changes, difficulty with expression, aphasia. If it's the motor aspect of the brain, which is right here, the motor strips, if those get involved, you get ALS, and so forth. So the first symptoms that people present with are often telling us where the disease is starting. It's not telling us what's there, but where the first changes are taking place. And that's important because, for instance, in frontotemporal dementia, I'll finish with this slide, in frontotemporal dementia, there are very, very specific regions of the brain that are always involved first. And those are really well represented here. You probably recognize this slide. It comes from UCSF. But these are the regions of the brain that are always involved in FTD, the frontal part of the insula, the orbital frontal cortex, the temporal pole, the pole of the temporal lobes, which is where this particular patient was involved the most, the cingulate gyrus over here, and the frontal pole, the frontal part of the brain. And ultimately, when the disease progresses and starts to damage the tissues more and more, we end up with a very, very damaged brain. And as you can see from this one, from this particular picture, this is a patient that died from frontotemporal dementia. We have just devastation of the cortex of the frontal and to some extent temporal lobes, but the rest of the brain is fine, the back of the brain. You had a question.
Well, I had a question 2 slides ago. You were showing where the kind of, yes, I just want to see where the ALS line is.
Yeah, this is not the best pointer for that. Well, the central sulcus, which is probably about here, the central sulcus, the motor strip is right in front of it. This is that controls the spinal cord that then controls the muscles, and this is the sensory strip behind it.
Thank you.
And I'm just going to interrupt you for a second to ask if you have a question like you just did about a slide, go ahead and ask it, or if there's something you don't understand. If you have a more general question, then we'll be sure to leave you all lots of time at the end to ask those questions.
So, as I mentioned, the frontal lobes and the temporal lobes are responsible for a lot of things that we consider social, personality, interacting with people. And so the main manifestations of a patient that suffers from frontotemporal dementia are going to be along those lines. And these are part of the diagnostic criteria for the disease. So apathy, disinhibition, doing things that are not always kosher in public or with friends or with strangers. Lack of insight, changes in eating habits. These are probably all things that you've experienced. Compulsive or ritualistic behaviors, and emotional blunting. Although the story we heard today was an inverted one, where the mother didn't suffer, but she was a very hard and stringent person, and then as the disease progressed, she became more open and loving. Now, I mentioned we talked initially about the frontal and the temporal lobes as those areas that are affected at first. What if the other parts of the brain get involved? So instead of just sticking to the frontal lobes, what if it goes inward and affects the basal ganglia? I'll show you what the basal ganglia are in a second. But typically when the basal ganglia and the cortex that are associated with the basal ganglia get involved, we get another syndrome that looks a lot like Parkinson's disease called corticobasal syndrome. When the brainstem is involved, and that's a little bit lower down, the brainstem is involved, the brainstem controls eye movements, and so the syndrome that develops from that is a progressive supranuclear palsy. That's another kind of Parkinsonian syndrome. So both these syndromes, Parkinsonian syndromes, and this is just for your benefit to give you an idea of which parts of the brain we're talking about. But the basal ganglia are these really, really deep nuclei in the middle of the brain that are involved in Parkinson's disease. But when they're involved in the way they're involved in frontotemporal dementia, the syndrome is a little bit different and doesn't respond to the usual medications that we use to treat Parkinson's disease. And the brainstem is exactly what it sounds like. It's the stem of the brain. It's at the base of the brain here. And the very top part of the brainstem is called the midbrain. And when that part is affected, eye movements become abnormal. And that leads to another syndrome where eye movement abnormalities are more significant, progressive supranuclear palsy. In the same way, we can think about the disease affecting other parts. For instance, if it affects the motor cortex itself, then we'll get amyotrophic lateral sclerosis. If it affects area, or motor neuron disease, if it affects areas that are responsible for language, we'll get primary progressive aphasia. So again, just for your benefit, I'm showing you those areas of the brain that we were talking about. The motor strip is over here at the top of the brain. Those are the upper motor neurons, and these are the lower motor neurons that come from the spinal cord over here. When both those neurons become affected, we can make a diagnosis of ALS, and that's what my patient had. This is just a very simple table that I created to sort of put these things in perspective. We can have the Parkinsonian aspects of FTD, where we have axial stiffness, eye movement abnormalities, early falls. That's PSP. If we have asymmetric involvement, so the Parkinsonism only involves half the body, apraxia, that's an inability to do complex tasks with our arms or our hands, and complex sensory deficits, then we're dealing with corticobasal syndrome. If the motor neuron, if the motor strip is involved and attached to it the spinal cord, we'll get muscle weakness and atrophy, the dysarthria and dysphagia, trouble speaking or trouble articulating and trouble swallowing, fasciculations, and a more rapid course. And that's the amyotrophic lateral sclerosis, ALS, or motor neuron disease. Sure. So if you have a stroke that involves the sensory area, you might lose sensation to half your body. That's a pretty simple sensory deficit. More complex sensory deficits might be your ability to tell that you're holding a key in your hand. So I put the key in your right hand. You don't know what's in your hand. I put it in your left hand. You touch it a little bit. Oh, this is a key. So that's a more complex sensory deficit. Does that answer your question? Yeah. So you can imagine, I started this from the beginning where I told you this is where the disease starts, this is the other parts of the brain that get involved, this is how it evolves. So it's easy for you to say, oh, well, this is a FTD. But imagine if you're seeing the patient for the first time and you're seeing them for one of those symptoms. The aphasia, the motor neuron disease, the falling, the disinhibition, the unusual depression. It might be hard to put all that together, especially if you're not thinking globally. So I often think about this kind of problem as it depends on which doctor you are and what part of the body you're putting your hands on. A little bit like the blind man trying to determine that this is actually an elephant. Part 2, what's the pathology? What's the abnormal protein that collects in the brain? This is the brain of somebody who died from Alzheimer's disease. It's very shrunken. It's about a half to a third of the weight of a normal brain. Most of it is gone in contrast to the FTD brain that I showed you earlier. And if we look at the tissues of this brain, we'll find two things. We'll find a lot of things, but we'll find two main things, which are the plaques and the tangles. So that's the abnormal pathology that accumulates in Alzheimer's disease. In Pick's disease, or in FTD, there are, as I mentioned, abnormalities that appear as well. But those abnormalities are not the same from patient to patient. They can be very different. And in fact, for a while, we were only able to find abnormalities in about half the patients that suffered from the disease. And the other half, we didn't know. There was nothing wrong with the tissues. But technology has allowed us to detect these changes more and more. And now we're actually able to say in about 95% of cases, oh, this is the abnormal protein in this particular patient. So in Alzheimer's disease, I mentioned plaques and tangles. In FTD, there are many different types of proteins that accumulate, but there are two that are really the most frequent, and that's tau and TDP43. You've probably heard these terms before. Tau accounts for about 40% of patients, and it's most of the time the one that's associated with Parkinsonism. So the PSP and the CBD are almost always associated with changes in tau. That's relevant because if we're going to treat this patient with an anti-tau agent, it better be one that has tau. The other abnormal protein, the most common abnormal protein, is TDP43. It accounts for a little bit more than tau, probably 45% or so, and it's the one that's also most associated with motor neuron disease. So there's a pattern that's developing here. If you have tau, you're more likely to have Parkinsonism. If you have TDP43, you're more likely to have motor neuron disease. Tau isn't all the same in everybody. So these are just different kinds of ways in which tau can be seen. And I'm not want to belabor any of the details here, but as you can see, these pictures don't look at all the same. And these pictures represent different forms of tauopathy. A tauopathy for PSP, a tauopathy for Pick's disease, a tauopathy for CBD. And the same is true of TDP43. It can present in different ways. It can be seen in different ways in the tissues. And that leads to the different presentations of the disease. This is just a small graph to show you, to give you a sense of where we are in terms of understanding how many different types of pathology there is. 45% for TDP43, 40% for tau, and then a smattering of these others that we don't really understand as well. And the last question I wanted to answer is, what's the mechanism? Why does this happen? Well, that's $1 million question. In most cases, we have no idea. But in the cases, in most cases, we call that sporadic disease. So the proteins accumulate abnormally. We don't know why. We don't know what triggered them. We don't know why they're there. Potentially a polygenic or a multigenic situation where there's many, many genes that are contributing to the syndrome. But we're just grappling with that now. But in many circumstances, in FTD, this is more true than in any other neurodegenerative disease. About 10%, at least 10%, and in some cases, in some groups, as high as 30 or even 50% of cases, have a gene, a single gene that causes the disease. So these are the disease-causing genes. If you have the disease, if you have the gene, you get the disease, autosomal dominant. The gene that codes for tau is one of those. And obviously a defect in the gene that codes for tau will cause a tauopathy. Progranulin and chromosome 9, open reading frame 72 is another gene, two other genes that cause accumulation of TDP43. Chromosome 9, I think I'm going to move things along because I have been talking for about 20 minutes now.
If we want to maybe
Yeah.
go through the other presentations, and if we just leave you your presentation there.
Yes.
Or do you have a point where would we
I've got about another, I mean, let me get through 3 more slides or so.
Okay.
Yeah. My calendar is trying to take over. It's taken over completely. All right. Yeah, the next few slides are just trying to put this in perspective. Thank you. So I'm a busy guy. No. All right. So again, trying to put things in perspective, we think about these disorders in terms of the molecular subgroup. What's the protein abnormality? Is it tau? Is it TDP43? Is it one of these others? The abnormal protein that's depositing. What are the clinical subtypes that we see? CBD, PSP, PID, that's Pick's disease. And then what's the gene that's associated with them? So this sort of puts things in a nice systematic way of thinking about it. In the last 2 slides, I've mentioned that there are genes that cause both FTD and ALS. There are genes that cause only FTD, and there are genes that cause only ALS. You can see from here that there's some that are very critical. Chromosome 9 is chromosome 9 ORF72 causes both, and it's probably the most frequent protein associated with either FTD or with ALS. So it's one of those proteins that we're really trying hard to understand. How does it lead to the pathology, and can we find a way to stop that? Hopefully what we discover when we figure that out, we'll be able to apply to sporadic cases as well, not just the familial cases. And again, putting this into a whole, you can think of FTD as a group of different pathologies, of ALS as a group of different pathologies. But in the middle here is TDP43, generally caused by chromosome 9 mutations. Yep, I think I'll stop there. Thank you. What's that?
Can I borrow your computer, please?
The research part.
And thank you, Dr. Leger. And our next speaker, you may have already heard earlier today, Jamie Fong. She is a genetic counselor at UCSF Memory and Aging Center, and she also facilitates a telephone support group for adult children who are caring with individuals who have FTD.
So, oh, it's, yeah. All right, thank you. Thank you, Debra. How's everyone doing this afternoon? Good, good. I hope everyone enjoyed the morning talks. Oh, thank you. Yeah, great. Yeah, no, oh, thank you. Okay, got it. Okay. So I'm struck by all the personal stories that we've heard thus far. The stories about how people have adapted or are still adapting to FTD and related conditions, invaluably contextualizes what I and my colleagues do every day and motivates me to keep doing what I do and help families as best as I can. So thank you for taking time out of your afternoon to be here. I'm kind of back to talk a little bit about C9 or F72 genetic testing and counseling. So if you'd heard me earlier today, I'd kind of introduced this particular family where the history is very suggestive of an inherited form of FTD. And so I'd like to kind of bring us back to this family and think about kind of who in the family should get tested, certainly if a gene isn't already known. I talked about how once you have the family history in hand, it's good to discuss with others in the family who might be most appropriate for genetic testing. And you'll recall that I had said people with symptoms should be tested first. Certainly if you don't already know the mutation in your family. If it's already known, then healthy adult children can get tested if they wish. But if it's not known, it's best to start with someone with symptoms. And I'll kind of go into that. So as a healthy adult child, you may wonder, well, gosh, can't I order my own genetic testing? With the wide availability of at-home genetic testing or direct-to-consumer genetic testing, you might be pretty skeptical of what I'm saying because there's lots of kits out there where you can spit into a container, mail it in, and get results, through the internet in a matter of weeks without the help of any healthcare provider. So the recommendation that I'm making about getting someone who has symptoms first tested is not without reason, but I'll just say first that with regards to at-home testing, it actually does not give you information about genetic FTD or ALS or related conditions. So I know that this group is inclusive of individuals facing PSP and CBD. I'll be talking specifically about FTD ALS. But the at-home genetic testing doesn't provide information about risk for CBD or PSP as well. So that's one thing to keep in mind. So if a family is interested in FTD ALS genetic testing, that should be ordered by a healthcare provider. And we'll again come back to this idea that, yes, you can begin testing a healthy adult child, but there are limitations. And as long as someone is aware of these limitations, there shouldn't be any reason why someone might not want to continue with that. So coming back to this family, let's kind of hone in on this adult daughter of this person with FTD. And let's say that she does proceed, without knowing the family gene already, she proceeds with genetic testing for herself. And say she learns that she is negative for the C9 mutation. So one might think one possible scenario for that result happening is that her dad with FTD has the C9 mutation, but that the healthy daughter just did not inherit it. Now, of course, that's the ideal scenario. That's the kind of news we want to be able to give all our families. However, that negative result that she has is a little more complicated than that. And if you don't already know the gene in the family, it's possible that the daughter tested negative not because there's a C9 mutation in the family that she did not inherit, but rather there could be an as yet unidentified gene running in her family, which and certainly we can't ignore the family history. Remember, if you go back to the tree, she has many relatives with ALS, another relative with dementia, and then this questionable bipolar diagnosis in her grandmother. So still very suggestive of an inherited single gene condition. So it's very possible that in fact her dad has some other gene that she is at risk for. And so without already knowing and confirming in someone who already has symptoms the presence of the C9 gene, we actually can't distinguish between these two scenarios. And they're pretty profound, right? One is saying there is no genetic risk for the healthy adult child. And the other one, the genetic risk is undefined. So that's kind of the value of first testing someone with symptoms. Now, understandably, there may not be someone with symptoms available to test, and healthy adult children are left with perhaps testing themselves. And certainly if, gosh forbid, someone's result came back positive, again, in this scenario, for the C9 mutation, the risks associated with that are more straightforward, but it's always that potential for what happens if it's a negative genetic test. So certainly if that individual, again, going back to this family, if her father or uncle or her father's cousin were tested first and were found to have the C9 mutation, well then testing becomes available for all the healthy individuals in the family. And this is known as predictive testing. So it's a unique scenario, and it comes, and coming with it are unique considerations that I think are worth pointing out. So when you're conducting genetic testing in someone with symptoms, that's considered diagnostic testing. You want to be able to confirm the diagnosis. And in essence, another way to put this is that testing someone with symptoms, it becomes an ill person's now. By contrast, when you're testing someone with no symptoms, this is considered predictive testing. Can we predict one's future? What lies ahead? And as you might imagine, questions surrounding do I want to know, do I not want to know, are different in these two different scenarios. And the question that we end up asking individuals who are at risk for their family's gene, it becomes this, do I want to know if I will develop a debilitating neurologic condition for which there is yet, and I think yet is the key word here, because there's a lot of hope and optimism about therapies and a cure in the future. But for now, today, there is no cure. So pretty important question, something that we want all our at-risk individuals to take some time with and think carefully about if this is right for them and the time at which one might want to know. Some reasons why someone might want to know this information is that the uncertainty of not knowing kind of where you fall, do you have it, do you not, can become unbearable. And I've worked with a number of families over the years and have been told many times that the not knowing is sometimes worse than knowing that you're at risk for your family's illness. People want this information to make life choices, whether it's about their education or career or their relationship. I'm also often told that the not knowing phase in one's life, it just feels like you're in limbo. And that perpetual in limbo can really hamper or hinder life decisions and where one wants to go. And then, of course, making future plans, right? If we're anticipating a future requiring the help and care of others, do we want to set things in motion so that the burden can be eased on the family, whether it's financial planning or care planning or family planning, right? So this is one reason why young people are particularly interested in having this information. It's so that they can plan their family, from overarching questions of do I want children at all to questions about do I want biological children, and if so, how can I find a way to have biological children and virtually guarantee that they're not at risk for the family illness. There is technology that makes that possible. And of course, to inform others, right? To prepare a partner, to prepare a child, so that, again, I turn to the stories that I hear from the families I work with, and to spare others this notion of the rug being swept out from under them and being blindsided. On the other hand, there are reasons not to know, right? There are individuals for whom uncertainty is intolerable. Not being able to do something immediately about it. Although, again, we're hearing about so many breakthroughs and discoveries and medicine trials that are on the horizon. So still, for some people, uncertainty can be unbearable. Some individuals may choose not to know in order to keep hope alive. So hope is such an essential quality of our lives. And this kind of speaks to the potential burden of information. For young people who seek out this information, they are potentially learning years in advance of first symptom. And so the question becomes, can you live with that information? And then there are others who would live no differently, right? It's not going to change how I live my life. I want to be able to know as much about me and my body as possible. And so this is not a negative piece of information to know, but rather something that's empowering. And then, of course, many tell us that I need to know so that I can tell my children, so that they can plan their lives. But at the same time, we've been told that, well, if my adult child is going to continue on with their life no differently, so that maybe that's another reason not to know. And then still others might have some concerns about genetic discrimination. So that's concerns about being discriminated against or mistreated just based on your genetic information. Another thing to keep in mind is, as someone at risk is faced with this question, do I test, do I not test? You have to consider that there is some element of uncertainty, no matter what. That we don't have a great way of predicting the exact age of first symptom in someone. There's a range, but that range isn't necessarily going to capture every single individual person. And then what about the unpredictability of developing FTD or ALS or both? At least with C9, we know there's risk for both. We know that there are families that have both conditions. Some in the family get ALS, some in the family get FTD, and we don't really know exactly why that is. We can't yet predict for someone in advance of first symptom whether or not they're on the road to ALS or on the road to FTD. Hopefully, through the large research consortia that's happening now, we'll be able to better address these questions, but for now, there is still some unknowns. And then, of course, as many of you have experienced and seen in your own lives, diagnosing first symptoms can be incredibly difficult, right? These are slow and insidious conditions, and it's often not until symptoms can become quite disabling that a family becomes aware that there's something going on. Even in the face, even in the setting of knowing that there is a genetic mutation, the question of, is this the first symptom, still comes up. And of course, hopefully our knowledge is growing and changing, but we still don't have a proven diet or lifestyle that can definitely stop or slow down or reverse symptoms. So, in the face of all this, does the predictive genetic test still make sense for that person, for that healthy adult child? So that's where the limitations lie. That even if you know you have the C9 mutation, there is still some associated uncertainty, and knowing before someone has symptoms may impede your ability to obtain certain insurances. So those insurances include life insurance, long-term care insurance, and long-term disability insurance. Health insurance is protected by law, by federal law, and many states have additional laws to augment that. But it's still, regardless of the presence of laws, there are still concerns about that, about insurability. So if you or someone you know is thinking about this genetic test or has questions, I think it's prudent to reach out to a genetics professional. I showed this at the morning talk, but there are genetic counselors in your area, and alternatively, if you reach out to the Artful and Lefties research networks, you could get genetic information and genetic counseling information that way. So with that, I just want to thank everyone. So, thank you.
Thank you.
I saw a question, but I think we're saving questions to the end.
Yes, please. And we have one more speaker. and that will be Dr. Miki Paul. She's a professional psychologist with a practice in the San Francisco Bay Area. She's also the facilitator for the only national support group for folks who are care partners of someone with FTD and ALS, and she brings to the table the unique perspective of having been a care partner herself for her husband who had FTD ALS.
Thank you. I lost my husband years before I lost him. We were living the dream life. I worked as a psychologist, my husband an electrical engineer. We had a house with a few acres. We had a cabin. We were traveling. We're just really living the dream life. And then in 2010, I noticed all sorts of changes in his personality. He was a very gentle person. All of a sudden, it seemed to me out of nowhere, he would start having these temper outbursts. He smashed my computer. He started swearing. This is a very polished man who had never sworn before. One day I counted, he swore like 67 times. So he became kind of anxious too, very unusual, very unlike him. So one time we're driving home and he sees there's a fire in the distance. So all of a sudden he says to me, he says, "I just know our house is on fire." And he was just so anxious. It was so illogical. But again, I thought, wow, what is going on with him? Then he started losing his jobs. He could get a job as an electrical engineer. His resume was incredible, but he kept losing jobs. He always had a very good reason, it seemed. It was always somebody else's fault or a boss or somebody else. So, okay, you know, I kind of believed what he was telling me. So I kept wondering, who is this man that I married? Who is he? What's going on? And it's all very confusing during those times. Okay, and then all these cognitive changes I noticed. One time I sat down, I wrote down like 50 different cognitive changes. So I made a huge list to hand the neurologist. So let's see. He couldn't plan anything. He could fix anything, but then all of a sudden he couldn't seem to plan it out. So I noticed for any project, he must have gone back to the Home Depot like 10 times, you know, maybe getting one little thing at a time. He couldn't see he couldn't see the big picture at all. That was very, very unusual. He couldn't tell right from left, and this was a man who had the best sense of direction. I always relied on him. Well, I couldn't anymore, so that was another huge change. One time, actually this happened twice, he would go to bed. We went to bed early, say 9 o'clock, because he had to get up at 4, anyhow, for work. Twice, he woke up about 11:30 or midnight. He thought it was morning. So he made his breakfast, he made his coffee, he took his shower, and then in the morning he would, by that point I would wake up and say, well, what are you doing? And so he was just so mixed up about time. He never knew what day of the week it was, and he couldn't even think about looking down at the newspaper, because we always got the daily paper to see what day it was. So that was unusual. So anyhow, just unusual things, time after time after time. He missed medical appointments that he was supposed to go to. He forgot to feed the dogs. He would ask, "What's for dinner?" And then an hour later ask me again, what's for dinner? He would be cooking something on the stove and then forget that he was cooking something on the stove. He would take a shower and leave the water on, just on and on and on. I mean, I could go on for an hour of all the things I noticed. And then he started having trouble speaking. He couldn't find the right word. He called things by different names. A friend called me one day and wanted to know if my husband was drinking, because his voice started sounding very funny, very unusual. So he kept, let's see, what else? He kept misplacing things at home all the time and would always ask me to help him find things. He would go to the store, and I remember 6 times he left his wallet at home. Let's see. And one summer, you've heard about the perseveration of, they would get on one topic and just stay on that. Well, one summer, every single time he went to the grocery store, he would bring back salmon. And he did the grocery shopping. So one summer, I remember we had salmon like the entire summer. So, wow, I thought that was pretty strange too. And then finally, so years had gone by. So this is 2010. This is by the summer of 2014. Then we were on a trip, and he actually asked me to help carry luggage. This was a very strong guy. So that was very different. What? Me? I'm, Dr. Weakling. So anyhow, he would ask me to carry the luggage. The weakness in his hands, his arms. He couldn't lift pens up. He couldn't carry the cat litter bag anymore. He couldn't lock or unlock the front door. That was really weird. He would hold his hands very awkwardly when he was doing something. He kept taking naps all the time. This was a man who never napped. So he couldn't tear open his protein bars. He would come and ask me to tear open his protein bars. He lost weight without trying, like 25 pounds. So anyhow, this was an accumulation of everything. So it took me years to get him to go to the doctor. Finally, this was summer of 2014. I tried a different tactic, finally. I mean, I tried so many tactics. Finally, I cried and cried. I said, don't go for you, just go for me. It's for me. It's not for you. Let's go for me and get it over with. So he finally agreed. So what I did, I brought in the list of all the symptoms, and I just handed it without making any fuss about it to the provider, who actually looked it over. I was so pleased because, a lot of the times providers don't look at what the partner brings in. So we were fortunate. We were able to go to the VA, and the neurologist there right away, he FTD ALS, and then he saw several other neurologists who confirmed the diagnosis. So I became his caregiver for 16 months before he died. He died in 2016, 16 months after diagnosis. And just to give you an idea of a typical day with FTD ALS, one day I counted, I think I did 37 things for him. Help him get out of his, so this is a typical day about 9 months after diagnosis. Get him out of the hospital bed to his walker. He refused to use the wheelchair. I bought him the Cadillac of all wheelchairs, but he absolutely refused to get in it. So I had to stand by him while he walked to the other room, change his diaper. By then he was wearing diapers, help him get dressed, feed him with his feeding tube. So the VA suggested a feeding tube earlier rather than later. So I did get him a feeding tube. That was a tough decision. Do I do that or not? Brush his teeth for him, help him onto his lift chair so he could watch TV. That's what he did. Every single day he watched TV. He watched one channel, the golf channel, without the sound on. I took him to one of any day. I took him to numerous appointments. He unfortunately, he had an ALS neurologist and he had an FTD neurologist. So, you know, we had 2 neurologist appointments. At the time, there really wasn't anybody in town who really understood both diseases. So let's see, speech therapist, dentist, physical therapist, ALS clinic. Luckily, there was one in Arizona where I lived. We went to an ALS support group together, which was very helpful. Let's see, I would help him with his range of motions exercise that the PT showed us, you know, what to do. Helped him shower, brush his hair. I would read to him. I would, this again, 9 months after diagnosis, I had this app on the iPad, a ProLoQ to go. It was pictures to speak, because by then he could barely talk. And so I would try to teach him how to use this app. He never could learn. I mean, each day it was like a brand new day starting over. So we really, it wasn't useful. It was a shame. It was a, you know, $250 app. And let's see, what else would I do? I would help him with his cough assist machine, because he would just cough and cough and cough. It was awful. And help him with his BiPAP machine to help him breathe because of the ALS. Choking was the worst thing for me, to sit there and he would just choke and choke and choke and choke. And also, one of the worst things would be for him to wake up in the middle of the night and feel he just can't breathe. So, you know, lots of scary, scary things. Very, very challenging, extremely challenging to have the dual diagnosis. But really, we know it's really all of one disease. ALS is the most feared of all diseases. And then you add to it FTD, and it's a double whammy. When I think back about it, it really was a privilege to be able to look after him for those years. I mean, I really took it very seriously. In sickness and health, to death do we part. It was a heartache. It was a burden. I can't tell you how challenging it was during this time. I was desperate for help, and to find other people also going through FTD ALS. So I called the AFTD. I talked to Sharon Denny, this was in 2014, and begged her to start some sort of support group for caregivers of FTD ALS. I called the National ALS Group and begged them to start something, and they finally did in 2016. But unfortunately, I was only part of the group for 2 months, and then my husband died. But then about a year and a half ago, I was very grateful to be asked to lead the support group. And it is the only phone support group for caregivers of FTD ALS. So I'm going to hand you a flyer. Please pass it around. So getting support to me was the most significant help for me. You know, just even the 2 months that I participated in the support group, just knowing there were a few other people in this country going through something similar, what I was going through. Trying to get a team of people to help me, I had to fire several caregiver helpers, but then I was able to hire some so I could go to work. I cut down my office hours a lot, but going to the office was a relief to me to hear other people's worlds. It was, so much different from my own. I wasted a lot of energy trying to kind of resisting the way things are, lamenting, this is how it is. And eventually I just accepted this is our fate, do the best I can, one day at a time. I was anxious all the time. I remember, am I going to be able to hold myself up? Will I be able to have the strength to keep up with this horror of FTD ALS day by day, all the challenges? I was his advocate. Will I do a good enough job for him? Can I handle it? Concerned about him, will he have a peaceful ending to these diseases? So I remember the anxiety through those years. Information really helps. I read every book I possibly could. Of course, there's one really good book on FTD, and then ALS. I highly recommended, even though it's fiction, Lisa Genova did her homework. She interviewed, 10 or 15 families. She got it right. If you want to know about what ALS really looks like, the nitty and gritty, not only from the caregiver's viewpoint, but from the patient viewpoint. It's called Every Note Played by Dr. Lisa Genova. Really, really good. So information helped me. Every day was different. I would think, oh, well, tomorrow will kind of be like today, but it wasn't true. Every single day, something new, something old. Maybe he would seem improved a little bit, whatever that meant at the time, and then the next day, something else would come up. Something that really helped me, I made a book, and it's called the Book of Chuck, my husband. So what I did, I just accumulated photos, his resume, his incredible resume from his career, many things from his life, his time in the Air Force, things that he was proud of. Early on, I interviewed him, because just thinking I better get information while I can. So I wrote a lot of things in. I put in pictures from our life together, and just various things. I'll pass it around a little bit. But it really, first of all, it helped any of the caregivers that came over, because by the time they met him, they had no idea who he really was. So it helped them, plus anybody who came to the house would sit with him and go through the book. And my husband, he would just sit there and beam and beam. He couldn't talk by that time, but just going through the book, and people would comment, oh, you did this, you did that, look at this picture. So that it helped me, it helped him, and it helped the caregivers that came over as well. I used respite care. I did get a couple of the grants from the AFTD, and I used that money for respite. I went away twice while he was ill to see my daughters and my grandchildren. 5 days. I mean, it was super planning, making sure somebody was with him at all time, friends, caregivers. But I just highly recommend for any of you caregivers to use the grant money that's around. We were very fortunate. We were able to get VA benefits because of the ALS. The VA, they took 100% responsibility for my husband having ALS, as they do other veterans. Percentage-wise, more veterans have ALS than any other similar group of the population.
We're going to have to, if anyone wants to think we can stay here for a few minutes. We have a break outside if you want to go and take a short break. Our next session begins at 2:50. But I want to thank everyone for their